Good morning, everybody. You can see it's the early morning session of the last day, so we're deep in the 10, and it's such a huge auditorium. But nonetheless, thank you very much to the organizers for the kind invitation to speak here today. So I'm adding the South African flavor to the conference, and certainly my accent qualifies. That is my conflicts of interest. So David Denning wrote in an editorial in 2003 these famous words, fungi are flourishing in man. And certainly 20 years after he wrote it, this has never been more true. However, the World Health Organization in 2017 already published a critical pathogen priority list for bacteria. And it's only very recently, about a month ago, that I published a similar fungal priority organism list with help, of course, from some prominent researchers at the Sydney University. And you can see there in the critical group, it's the usual suspects. And it's all things we see a lot of in South Africa, namely Cryptococcus neoformans, Candida auris, and then the topic of today, Aspergillus fumigatus. So I thought to illustrate the difficulties of making a diagnosis of invasive Aspergillus in the ICU, to start with a case study. This was a patient we saw little more than a month ago at one of the ICUs where I work. It was a 79-year-old male patient. He was admitted with acute coronary syndrome and community-acquired pneumonia. He was a known patient with chronic atrial fibrillation. He's on a shopping list of all kinds of cardiac medicine, and his surgical history, he had bilateral hip and knee replacements. Although he was now a few years retired, he had worked in a cement factory, first on the floor in the factory and then later as a manager. He had no known allergies, but there was a sort of iffy diagnosis of previous pulmonary sarcoidosis. He was at the moment not, however, following up at the pulmonologist, and we couldn't find histology that proved this. He was admitted with type 1 respiratory failure, requiring high-flow oxygen, treated with cephalosporin, ceftriaxone. His sputum and blood cultures were all negative. His multiplex PCR was negative, and his COVID was negative as well. He received an angiogram and a stent, and he was discharged a few days later. Then he was readmitted with a diagnosis of recurrence of pneumonia. He required supplemental oxygen. His chest X-ray showed bilateral diffuse infiltrates in keeping with ARDS, and he required intubation shortly thereafter. Interesting to note, his platelets were 226 or 283, and his CRP was quite high, whereas proportionally to that, the procalcitonin was low. This is what his CT scan looked like, and I'm not a radiologist, but the radiologist commented that there were multinodular infiltrates, then followed with a ground class opacification that was especially pronounced in the right lower lobe. And the radiologist did make the comment that it looks like bronchopneumonia, but the diagnosis of invasive aspergillosis should be considered. The sputum culture yielded normal flora, but on the tracheal aspirate was PCR positive. It was quite a strong positive. We repeated it 2 days later just to confirm, and the galactomannan was especially high. So normally galactomannan in serum, we will take a cutoff of 0.5. In bronchoalveolar lavage fluids, we would take a cutoff of 1. 11.28 was quite high, and the patient was started on IV voriconazole. So if we look at the management of invasive aspergillosis in critically ill patients, it's an under-recognized disease. And this is probably the only good thing that came from the COVID pandemic, in my opinion, is that it actually sensitized clinicians to this diagnosis. Because if they don't think about it, they're not going to do the appropriate investigations, going to miss the diagnosis, and inevitably the patient will die. However, even if you suspect it, the diagnosis is not an easy one to make. the criteria of EORTC and even the ASP-ICU criteria that I've tried to establish to make, is this now definitive or probable or possible, it just doesn't fit very well with this group of patients. They don't present with the classical risk factors that we associate with invasive aspergillosis. The non-culture-based tests, such as PCR and galactomannan, are all validated in neutropenic patient populations. They're not validated in this critically ill group. And then the radiological features, we don't see the crescent sign or the normal signs that you would associate in a neutropenic patient. So the CT scan will show changes to before, but those changes can be almost anything. And then to top it off, although the mortality rate is very high, in excess of 50%, there's no recommendations for prophylaxis in these high-risk groups. So if we look at the incidence of invasive aspergillosis, and I'll tell you up front, the reason why I put up this slide is to actually illustrate this difficulty in confirming the diagnosis. Because the second EPIC study in 2009 had an incidence of 1.4%. The third EPIC study, published in 2020, had an incidence of 1.4%. And if you look at the ICU patients from Africa that was included, the number was 0. And that is impossible. What I think these incidences reflect is actually the lack of access to proper testing modalities in order to actually make this diagnosis. In some autopsy studies, it's a little bit higher. I think the true infection rate probably rather reflects that 6 to 17% in other studies. So these are the patients that we normally look for, invasive aspergillus, and where your money is, if I can put it that way, especially that very high-risk group, our acute myeloid leukemias, allogeneic stem cell transplant, and then some of the solid organ transplant patients. However, if we look at the risk factors for the non-neutropenic patients, this list is of course expanding. And in 2020 and 2021, probably the biggest single risk factor was, of course, the COVID-19 pandemic. But there's also some other factors there, including prolonged steroid treatment. This would normally be doses of prednisone more than 20 milligrams per day. Patients with COPD, we know, are predisposed to it. HIV infection, especially if they've had tuberculosis as well. But then probably about, if you start looking in a normal ICU setting, 80 to 90% of your cases will be patients with severe sepsis or septic shock, and then respiratory insufficiency secondary to ARDS, and most likely due to influenza or to bacterial pneumonia. If you start focusing on that group of patients, you're likely to find it. The other one thing I want to point out is, of course, the concentration of Aspergillus spores in the air, and we saw that this last year, unfortunately, in one of the other hospitals where I was involved, they, during the Delta wave, had to change the light fittings in the ICU. And you could see a week or two later, there were quite a few more patients diagnosed with this. Severe influenza has been well described to be a major risk factor. The incidence can be as high as 19% if it's patients that end up ventilated in ICU. And then, of course, mortality is quite significant. So it's up to 19% of those patients, and it's early onset. They can be as early as day 3 in hospital, already present with invasive aspergillosis. So to confirm the diagnosis, as I've already mentioned, this is not an easy thing. The only definitive diagnosis is in fact biopsy. But we know critically ill patients, they've often got low platelets, they are unstable, so they will not be able to withstand the procedure. They might have other clotting issues as well. So I don't think I've seen in a critically ill patient any lung biopsies being done. So if you could have that, that would be definitive, and that would be first prize. However, in the absence of that, there is not one other test which will distinguish between colonization and infection. Cultures, or like in the ASP-ICU criteria, the first starting point would be a positive culture. However, in our lab as well, the sensitivity of cultures are quite poor, and it's quoted as between 20 and 50%. So if culture is your starting point, you're probably going to miss 50% of these patients. The other non-culture-based tests, so I've said before, it's been validated in neutropenic populations, and then preferably you want a lower respiratory tract sample, such as a BAL or a non-directed BAL. Unfortunately, that is also not always available, and in fact, for the past 2 years during the COVID pandemic, the most common sample that we received were tracheal aspirates. So you can do galactomannan. It's preferred to do it on the respiratory tract sample. The sensitivity in serum is extremely poor in non-neutropenic patients. The reason is quite simple, because the neutrophils will clear the circulating antigen. So it will be positive less than 20% of the time. So we do galactomannan on the respiratory tract samples. Aspergillus PCR, it used to be not recommended in the guidelines because it was often in-house PCRs and not standardized, but I think the evidence is now moving towards accepting Aspergillus PCR, and certainly in my lab, we get very good results with it. Microscopy and culture, I've mentioned the limitations, and then the 1.3 serum beta-D-glucan, I must say we have not found that to be very useful because the specificity is extremely low. So the bottom line is, if you've got a patient who's critically ill, they were doing maybe a little bit better and then they deteriorate, there's new infiltrates on a CT scan, and you start to suspect that this patient might have invasive aspergillosis. You're not going to have a perfect test, but most likely, if your galactomannan, especially on a BAL, is positive, it's highly likely that that patient does have invasive aspergillosis, whereas if it is negative and your PCR is negative, then you can be fairly certain that you've actually ruled this out. The treatment of pulmonary aspergillosis is pretty similar to in our neutropenic patients. Voriconazole, of course, is still the A1 recommendation drug of choice. Isavuconazole is now also in the guidelines, and I think recently there's been trials that actually prove that posaconazole is also a very good option. Echinocandins is not recommended as first-line therapy. There may be some very select cases where a patient might benefit if echinocandins are combined with your triazoles, and that would be usually where there's a very high galactomannan level early on. Amphotericin is of course not recommended in European or US guidelines, but if you're in a resource-poor country such as South Africa, where even in private you struggle to get access to liposomal amphotericin, we certainly still use it. And then the duration of treatment is an absolute question mark. I think if your patient survives long enough, they usually estimate it should be between 6 and 12 weeks of treatment. And then as a guideline, it's like you need clinical improvement and then resolution of your signs on your CT scan, but who knows. Voriconazole, of course, has been a workhorse drug for us, but it's got a lot of drug interactions because it induces the cytochrome P2C19, C2C9, and 3A4. So examples of drug interactions are numerous. In the COVID patients specifically, just to make it more interesting, there was some issues of drug interactions with dexamethasone and remdesivir, which we used a lot of. And there's also great intra and inter-individual variations in levels. In other words, two persons who weigh exactly the same can get exactly the same dose of voriconazole, and their levels, if you check trough levels, will be like anything from 0 to toxic levels above 10 in the same person with the same dose. So this is really a drug that I think it's imperative that you should do therapeutic drug monitoring, not least because the therapeutic index is actually quite narrow. So in a critically ill patient, you're aiming for a trough level of between 2 and 5.5. Once that trough level hits 6, the incidence of neurotoxicity is 100%. The only short advantage with that is most of our patients are ventilated and sedated. So they cannot tell you that they are seeing things and having hallucinations that you don't see yourself. So these trough levels, we normally start checking for them about day 4 after we've started treatment. And it should be repeated. If your levels are within target, you should repeat it a week later just to make sure that it is still on target. If there's any changes in the patient's clinical condition, because as I've mentioned before, mortality is quite high. And if your patient is not getting better, you've got to ask yourself, was my diagnosis correct in the first place? But before we start thinking about things like resistance, etc., and I'll say a little bit about that, check that those levels are therapeutic, because it might be that the patient has subtherapeutic levels and that is why they are not responding. If you start any new concomitant medication, or then if toxicity is suspected. And this is really one of the drugs in the hospital where I would strongly recommend a clinical pharmacist be involved in the management of the patient. Unfortunately, this is a disease that often affects patients who need ECMO. And voriconazole, we know, sequestrate into the ECMO circuits. So this is just one example case study that was published where they actually needed to give 6.5 milligrams per kilogram 3 times a day in order to reach therapeutic trough levels, but it took them 9 days to get there and the patient passed away. So usually if we have a patient on ECMO, we will start off with our loading doses, etc., but we tend to start very early on adding, for example, liposomal amphotericin to the treatment until we know that our levels are therapeutic and steady. Isavuconazole is a new new for us, it's not available in South Africa yet, triazole. It's also available IV and oral formulations, and for patients with acute kidney failure, it's got the advantage that it doesn't have the cyclodextrin molecule attached to it. In a secure trial, it was shown to be non-inferior to voriconazole, but the incidence of side effects, drug-related adverse events, were 43% less than with voriconazole. So there would be an option if you've got some toxicity problems with voriconazole, which we unfortunately see from time to time. What about azole resistance? So this was first described in 2007 in the Netherlands, where when they looked historically, isolates up until 1998, the incidence of resistance was 0. And then subsequent to that, between 2002 and 2007, they found that 10 out of 81 patient isolates showed multiple triazole resistant Aspergillus. Does this hold true for any other geographical reasons? I think not. It's probably one of the higher end scale levels. And certainly we haven't tested a lot of isolates, but in South Africa where I work, this does not seem to be an issue. So I think if you need to decide whether you need to do sensitivity testing routinely or to look for it, you need to know what's going on in your own geographical area. Of course, this is not just secondary to the use of triazoles, so one would have expected if it's like bacterial resistance, it would be patients that's been on posaconazole prophylaxis. So that's why guidelines would suggest if they've been on a triazole prophylaxis and they get sick, you need to treat with a different class of antifungal, such as liposomal amphotericin. However, in that study in the Netherlands, most of those patients were primarily infected with a resistant strain, and this is of course due to the use of triazoles in agriculture. The mechanisms of azole resistance are difficult, okay, and it's more than one type. So you can have active efflux of the triazoles. You can have overexpression of that cytochrome P51A enzyme, or then there can be amino acid substitutions which actually decrease the binding ability of your triazoles. So the good thing about this, those have been well documented, and it enables us to have molecular targets so that we can test with PCR if that resistance is available. But again, the caveat is there, you need to know if that's the resistance mechanism in your isolates, in your geographical area. Because, for example, that L98HTR34 mutation, that's only responsible for about 50 to 60% of the resistance that is found. So in other words, if that is what you rely on, then you might actually miss it if you don't do phenotypic sensitivity testing. So in conclusion, this has flown by. I should have spoken slower, but it will give us some time for questions. I think in my experience, certainly invasive aspergillosis is more common in critically ill patients than we suspected before. And as I've said before, it might be the one good thing that came out of the COVID pandemic. Our clinicians are now sensitized to the probability that this might be there, and they actually, if they don't find anything else, they actually start looking for it. So, as I've said before, where you will find most of your patients will be patients with sepsis or severe respiratory insufficiency, and it will be patients with ARDS, influenza, or bacterial pneumonia. But in the absence of histology, there is no perfect test. And none of your tests are going to distinguish between colonization and infection. We should remember, however, that we shouldn't use it as a fishing expedition, but we look at our patient, we look at radiological changes, etc., and in those patients we request the tests, and then of course we don't treat lab results, we treat the patient, and we can quickly see if that patient is actually responding to the treatment or not. So we combine that, because if not, the mortality is very high, and in most case series it's in excess of 50 to 60%. Thank you.